Start in the exam chair. A patient presents with a red, aching eye. Through the slit lamp, inflammatory cells and protein flare drift in the anterior chamber. It looks like a textbook case of simple inflammation. The immediate instinct is to diagnose acute anterior uveitis, prescribe topical steroids, and move on. However, stopping at the front of the eye is a dangerous clinical trap. This presentation often masks posterior uveitis. Anatomically, this involves inflammation occurring posterior to the vitreous base, specifically affecting the choroid and the retina. When severe inflammation brews in those posterior tissues, inflammatory cells migrate forward. They spill over the lens and into the anterior chamber, mimicking the signs of an isolated anterior disease. Because of this spillover, the diagnostic standard is absolute. You cannot diagnose acute anterior uveitis without definitively proving there is no posterior uveitis. Missing this underlying diagnosis is a failure of care. Posterior uveitis is frequently sight-threatening, leading to permanent structural damage in the retina if it goes undetected. While an anterior flare-up feels rapid and painful, posterior disease is typically slow-moving and chronic. Treating those anterior cells without visualizing the fundus means you are suppressing a secondary symptom while the primary pathology remains active in the back of the eye. For posterior segment inflammation, the standard acute versus chronic timeline is often inadequate for determining the immediate threat to the patient's vision. Advanced clinical practice requires a more functional mental model to classify the disease state. You must determine if the condition is currently active or resolved. An active state indicates an ongoing immune response. The tissue is sustaining damage, and cellular exudation is actively spilling into the surrounding fluids. A resolved state is not necessarily a cure. It represents a latent phase where the inflammation has burned out, leaving behind permanent chorioretinal scars. Upon fundus visualization, your primary task is to assign the patient's presentation into one of these two categories immediately. The management strategy depends entirely on whether the disease is mobilizing right now or merely lying in wait for an opportunity to reactivate. When taking a history, the dominant symptom that should alert you to posterior involvement is the sudden onset of floaters. In this clinical context, these are not age-related collagen changes. They are physical debris resulting from inflammatory exudation directly into the vitreous. Within the eye, one of the primary signs you are hunting for is snowballs. These present as small, gelatinous deposits of inflammatory debris, which typically settle in the inferior vitreous. A more severe structural sign of chronic inflammation is known as snowbanking. This appears as a gray or white fibroglial plaque forming a membrane that overlies the inferior pars plana. It is notoriously difficult to spot. Because it sits on the ora serrata, identifying snowbanking requires maximum pupillary dilation and scleral depression. Finding these vitreous signs triggers a complex diagnostic pathway, splitting cases between infectious causes, like syphilis or toxoplasmosis, and systemic inflammatory disorders, like sarcoidosis. To navigate this list, you look for specific markers on the retina, classifying the lesions as either unifocal or multifocal. These vitreous signs are the physical fingerprints of a systemic battle playing out in the posterior segment. The ultimate model for latent posterior disease is ocular toxoplasmosis, the most common infectious cause of retinochoroiditis. The pathogen, Toxoplasma gondii, enters the bloodstream after a host consumes undercooked meat or is exposed to cat feces. It crosses the gut mucosa and migrates to neural tissues, establishing itself in the retina. Once established, the pathogen deploys a unique survival strategy, encystment. The organism converts into a dormant form called a bradyzoite, sequestering itself inside a thick protective cyst wall. This cyst wall is physically impervious to the host immune cells, preventing the body from clearing the infection. The barrier is also resistant to standard pharmacological treatments. Most drugs cannot penetrate the wall to reach the organisms inside. This initiates a phase of chronic latent infection. To the clinician, nothing is visibly active, and the patient remains asymptomatic. During this period, the parasite survives without killing the host, and the host cannot kill the parasite. In a clinical context, this dormant state is what we define as resolved. This encystment explains why the disease is so remarkably persistent. The parasite has effectively established a permanent structural occupation within the retinal tissue. If the host's immune system declines, the cyst wall can rupture, releasing a swarm of active organisms back into the retina. This results in a fresh, violent locus of inflammation, which appears as a fluffy yellow-white area of retinitis. We identify this as a satellite lesion because it appears directly adjacent to an old, pigmented chorioretinal scar. The dark scar is the evidence of the previous resolved phase, while the new fluffy lesion marks the current active flare-up. This brings us back to the start of the clinical encounter. The vitreal haze and the anterior spillover cells are the visible leak from this posterior rupture. Every active flare-up is effectively a leak from a reservoir that has been embedded in the tissue for years. Because your goal is to move the patient into the specialist care pathway with a clear, evidence-based diagnostic suspicion. This reiterates the golden rule. Dilation and a thorough fundus check are mandatory for every case of anterior cells. In an eye without a cataract, the view should not be hazy. If it is, that haze is the evidence of the disease you are required to find. By looking past the anterior chamber and identifying the source of the spillover, the clinician moves from treating a symptom to uncovering the pathology.